The talk is about neonatal resuscitation in the delivery room. That was the request, and that's why I was asked to present. The talk will be very novice, very limited, just for people who's very novice, have no experience in neonatal resuscitation. So the objectives of today's talks is about how to do anticipation of resuscitation, what we need, about the antenatal counseling, about management approach, then the intervention, and what we do if the resuscitation fails, and how and when to discontinue, and when not to do resuscitation, and what we do after resuscitation. So anticipation of resuscitation, we know for sure that about 10% of newborns need some intervention, stimulation, some warming, positioning, maybe help with the feed. They need some help. And we know 1% will need intensive help, وليس extensive, intensive help. And that means they need frequent monitoring, maybe they need ventilation or breathing machine, they may need heart support, they might need fluid, they might need something intensive, they might need lines. That's what's good. So, and to anticipate resuscitation, also you need a skilled personnel and you need equipment. So you know how much, like let's say in your city there is 14,000 or 10,000 delivery per year. So you know that 1,000 will need some help, and 100 will need intensive help if you have 10,000 deliveries per year. Now this is a list of equipment that you need for a resuscitation. You need some suction equipment. I'm not gonna go details of these equipments. You don't need. You need something called intubation equipment to put tube in the upper airway, to put your tube and connect to the ventilation. You need a lot of medications like dextrose, you need epinephrine, naloxone, salines. You need a lot of medications. Everybody, can you mute yourself, please? Because I'm muting and you guys unmute. I mute and then you guys unmute. So please mute yourself. Like Mahmoud Karim, can you please mute yourself? So a lot of medication that you need, no need to memorize it, it's a list. You need other equipments like radiant warmers and some else. And you need additional equipment, like you need oxygen. It's much better to be central. You need plastic wraps. It's the same that we put the chicken in it, or the meat that we same. And then, in addition to these equipments, you need some equipment and preparation to high-risk deliveries. Why it's high risk? Because there might be a maternal problem, like diabetes or hypertension, or abnormal uterus, or very small size, or obesity. And you need also high risk for some fetal conditions, like abnormality, like twins, like small weight, something like that. Also, you need sometimes antepartum complications, like bleeding, or stress, or taking medication, or exposed to poisoning. And also you need to prepare to delivery complications. Mahmoud, please mute yourself. Mahmoud Karim. Delivery complications during delivery: trauma, obstructed delivery, bleeding. So these make high-risk deliveries. And in these high-risk deliveries, you need more equipment. And these are the list of equipment for high-risk deliveries. Again, we don't need to remember it. I'm listing it to you. There is specific problem in preterm babies. that need preparation, like the preterm baby cannot control the temperature, or they have breathing problem, whether it's RDS or respiratory distress or transient tachypnea or infection, whatever the reason. So they have inability to control temperature. There is infection sometime, and there's sometimes also organ damage with these newborn babies, the preterm babies. And therefore, you need special equipment too for these preterm babies. For example, you need polyethylene bags. And this bags is exactly like the bag that we put a chicken, or we save we save the food in it, or the same that wrap that we put a sandwich to serve it. It's exactly, we wrap the baby with this plastic bag to prevent, for example, heat loss. And for example, you need people who have a specific skill in intubating small babies. You need, for example, surfactant because of RDS. So you need a lot of equipment just for preterm baby. Before you do resuscitation, when you have the opportunity and the pregnant lady admitted to your hospital, sometimes you need antenatal consult. Why you do antenatal consult? You go and speak with her. You go and speak with her to tell her what is the percentage that your baby gonna make it. And if he gonna make it and we brought him or her to the NICU, what will be the course, for how long, and what is the outcome? What is the percentage of death and percentage of life? What is the complications, major complications and minor complications? Major complication is ability to talk, ability to see, ability to hear, ability to walk. So these are major complications. What is the chance of major complication of your baby concerning whether it's a general baby, whether it's a general term baby, or a specific high-risk baby, or a preterm baby? And the first question that couple will ask you, when the baby will go home. So you need, according to specific information, to tell them about how long they going to stay in an ICU before going home. When you have all this information, then how to approach, how to resuscitate. You ask yourself 3 questions. The first question, is the infant full-term? How we know? From last menstrual period, from ultrasound, and by asking the mom, sometimes from the weight, or some clinical examination. So you ask yourself, is this baby term or not? When the baby born, does he or she has a good tone, or floppy, or cannot move? The third question, when the baby delivers, is he or she breathing or crying? If the answer is yes to all these 3 questions, all of them, then you don't need resuscitation. So you go to well baby care. What is well baby care? Well baby care means the baby in the hospital, but he or she does not need hospital, but they are in the hospital because they are with mom. So you do well baby care. The first thing you do in well baby care, do what something called delay cord clamping. Because now we know that when you leave the baby attached to the placenta and some blood goes from placenta to the baby, it has better prognosis, better hemoglobin, better less risk of hypotension, better life, less risk of death. And there are different types of delay cord clamping. I'm not going to discuss it. Also, when the baby go to well baby care, need an examination by a neonatologist or a pediatrician within 24 hours. Also, you vaccinate according to your state or your county vaccination policy. Some places they do circumcision, and also you do screening. Screening is part of it clinical exam, part of it imaging like by ultrasound or x-ray, and part of it blood sample. And then you help the mom to establish the bond and breastfeeding. That's what we call it well baby care. I mean, a baby that has nothing but needs some care. If the answer is no to any of these questions, is the infant full term? Does the infant have a good muscle tone? Is the infant breathing or crying? If the answer is no to any of them, then you need to initiate your NRP. What is NRP? It is neonatal resuscitation program. It's a step taken by a group of people. All of them, they know what they are doing and they work as a team. This steps composed of assessment, judgment, intervention. Assessment, decision, intervention. Assessment, decision, intervention, and then you cycle. It's called NRP. NRP not only for physicians, it's for students, for receptionists, for a nurse, for administration, for physicians, for respiratory therapists, for everybody in the hospital. Or everybody should know NRP. Anybody dealing with a newborn baby. Does it need medical qualification? You need to know the steps. And as I say, the steps are of a cycle. Assessment, decision, intervention. Assessment, decision, intervention, and goes on. How we do it? The questionnaire, is the infant full term? No, he is preterm. Does he has a good tone? No, his tone is weak. Is he breathing or crying? No, he's not crying, and his breathing is labored. That's some breathing. So the answer is no. So I'm going to initiate NRP. What is NRP? I will do initial step of resuscitation. We'll talk about it. Does the infant respond to initial steps? The answer is yes. Then instead of well baby care, you go to monitoring care. What is the difference? They are the same. Well baby care and monitoring care are the same. What is here? You do more vital signs check. So you start to check the vital signs, which is respiratory rate, heart rate, sugar level, temperature, oxygen saturation, every 2 to 4 hours, depending on the status of that baby. Also, you might need sugar level. You might need to do blood gas to check the CO2 and oxygen and bicarb and pH. Sometimes you need to do sepsis workup. So you do blood culture, you do CRP, ESR, you do CBC, blood picture, and you might need to give antibiotics. But again, you do circumcision, you do screening, you keep the baby with mom, all this being done. So this is called monitoring care. What is monitoring care? Is for babies who responded to initial steps of resuscitation. Does the infant respond to initial step? The answer is no. So we go to second. If does not respond to initial step of resuscitation, then this patient needs intensive care. Intensive care means an ICU. Now, till here, any questions? Do you guys understand? Am I too fast? Am I too slow? Any question?
No, it's good, doctor.
Good. No questions. Okay, what is NRP? This is the algorithm of NRP, and we're going to discuss it step by step. You can see different colors and different shape. You can see the face's shape is the decision. You can see the face's shape is the decision. The regular shape is your assessment. The big shape is your action. So as we said, sometime we have the opportunity to meet the mom before delivery and do antenatal consult and tell her what will happen, how long it will be, what is the chance of survival, what is the chance of death, what will be possible course, how long gonna stay, and what is the complications. And then the baby born. So we ask 3 questions. Term gestation, good tone, breathing or crying. Is it yes? Then the baby stays with mom for routine care. Provide warm, clear airway, and continue the process. If the answer is no, so if the answer is yes, we will go to the process one by one, but this is a general approach. Then you do action. If the answer is no, you do another action, and then you assess. Then you assess. And when you assess, you have to answer yes and no. Always the answer is yes and no. So here is no, you do another assessment. If yes, then you do action. And then you do some other action. If the answer is no, then you go do another action. The assessment and the action is 30 seconds. So each assessment, decision, and action, 30 seconds. Decision, assessment, action, 30 seconds. Another assessment, decision, and action, 30 seconds. So you can see from here to here is 30 seconds. From here to here is 30 seconds. From here to here, another 30 seconds. So we get 1 minute. And then we continue. So this is the algorithm of NRP that we're going to discuss one by one. So we start, as we said, assessment, action, assessment, action, 30 seconds. So you evaluate, you identify, you intervene. That's your sequence, always. This sequence is 30 seconds. And each person has his or her assignment when you do the somebody do evaluation, some do identify, other do intervention, somebody care about respiration, other care about ventilation, about the heart, the temperature, whatever, documentation. So there will be a group of people doing the resuscitation. So they evaluate, they ask questions, or they do exam, they identify a problem, they intervene. 30 seconds, and then they have to repeat the cycle. So as we said, we start with the birth. We ask, can you mute yourself, please? Whoever not muting yourself. Jasim Mahmoud, can you mute? I'm gonna mute you. So you ask the question, is the baby term? Does he or she has a good tone? Does she or he breathing or crying? If the answer is yes, we go for routine care. Routine care means the baby with mom. What we do? We warm the baby to maintain normal temperature. How we warm the baby? We cover him, we put him on mom skin, we do zillions of things. We control the temperature of the room, we put him on resuscitate, whatever the reason there. We position him in a way so he can breathe. And here I want to stress on one very important point. Never, ever carry a baby from his leg. And if you see somebody doing that, you have to stop him. Never, ever carry a baby from his leg. And never, ever carry a baby upside down or oblique. Never. That's incorrect, dangerous, and has a lot of complications. When you carry a baby, you carry him or her by your two hands. You always, almost always support the head. You can leave anything but support the head. You can carry with one hand in a frog position or two hands. Now, if the baby is not breathing, do not carry him or her from the leg. Never, ever. Do not stimulate the baby strong if he is not breathing. It's like when you're fighting. The baby is weak. So you need to be with him gentle. So when you fight with somebody muscular, you need to hit him hard. But when you're dealing with somebody weak, then you need to hit him gentle. Otherwise, you kill him. So never hit the baby who cannot breathe. Never, if he cannot breathe, then ventilate. Very simple stimulation. So remember positioning for airway. Clear the secretion. Dry him. How I dry him? I bring a ready-made sheets, towels, whatever I have. It's better to be pre-warmed, and then I clean. When it becomes wet, I throw it. I use a new one. So each baby needs at least 3 sheets. And then continue to evaluate. Keep with mom. It's better to be skin on skin. You can do delay cord clamping. This is a wrong spelling, my apology. Breastfeeding, you need a full exam within 24 hours. You vaccinate, circumcise. So that's the answer is yes. If the answer is no, then you start your NRP. How we start NRP? We warm, like in here, there is not much of difference. We position, like in here, there is no difference. We clear the secretion, no difference. We dry. Can you mute yourself, please? Jasim Muhammad. So we do same. The extra step in NRP to the routine care is we do stimulation. I'm going to show you how to do stimulation. Do not allow the anesthetist. Mahmoud Karim, please, either you go to a quiet room or mute yourself. I muted you zillions of times, and then you keep back unmuted because there is a background in your place and it's very disturbing. Do not allow the anesthetist to hit the baby. Do not allow the anesthetist or the obstetrician to carry the baby by one hand. Never carry the baby from the leg. Never carry the baby upside down. Remember, excessive, vigorous, coarse stimulation will not help because simply the baby cannot breathe. So stimulation, how we do stimulation? So we will talk about it. So who's qualified for routine care? Term, good tone, breathing and crying. Infant who required further resuscitation. Infant who failed to meet the criteria for routine care. How we provide one, the first step in the routine care. We swaddle the baby. After we dry him by the 3 sheets that I said, we swaddle him, we lift him, or we put him on skin to skin with mom. Or we use plastic bag or wrap. The difference, the plastic bag is sealed. Wrap is you have to do it. If the baby is less than 1,500. If the baby is more than 1,500 grams, you don't need polyurethane bags or wraps. Or sometimes you have pre-warmed synthetic pads. It's like makhad, and they are warmed. So you put it below the baby. Or you put the baby under radiant warmer. If the baby needs oxygen, then it should be humidified and heated to a degree near the baby temperature. So that's how you provide warmth, the first step. Then you need to position. You need to position the baby. You position the baby in this way. Never ever carry the baby from the leg. The baby is not chicken. You can dislocate them. You can use, after 50 years, the baby can get, the patient, that person can get neuropathy. It can get dislocation 10 years later. Never carry the baby from the leg. Never carry the baby with head down. So this is the correct position. Whether you are carrying the baby or positioning the baby, always do like that. Okay? Your tip of nose, your lips and chin at the same level. Your tip of the nose, your lips and chins on the same level, transverse level. If it's left, the nose up, then it's very flexed. If the chin above the nose, the tip of the nose, then it's very hyperextend. And remember, this is not only when the patient or the baby on the service. It's even when you carry the baby. So this is the correct position. And why it's correct position? Because it makes all the airways in alignment. And therefore you open airway. Sometimes, not like adult, you need to put a shoulder roll. In adult, you put it below the occiput, in adult and more than 2 years pediatric. But here you put the roll under the shoulder to fix the position. Okay, whoever opening, can you please, Mahmoud Karim, can you please mute yourself? Okay, so we did one, we position the baby, and then we clear the secretion. How we clear the secretion and why? If we need a respiratory support. And we never suction before we put the baby in a correct position. So do not suction and the baby is upside down. The secretion will not go by gravity, by the way. They go by surface diffusion. So put the baby in a gravity will not clear. And when you suction the mouth first. Never ever suction the nose and then the mouth. Suction the mouth first and then the nose. How will you suction? You use a bulb syringe. This is a bulb syringe. So you put it in the nose, then you squeeze it, then you release it. Take it out. Put it again. Squeeze it, then release it. Sorry, you put it out, squeeze it. Put it in, release it. Take it out. Squeeze it. Put it in, leave it. Relax it. Take it out. Squeeze it. Put it in and squeeze. Take it out. So you put both sides. When you finish the mouth, then go to the nose. If the baby in an ICU, you might need mechanical suction. Never use suction pressure more than 100 centimeters. Do not put feeding tube in the stomach. There is no need. Or in esophagus, you suction only the mouth. Do not put the feeding tube till the stomach. It's harmful. You're not getting any benefit. Even if you get the secretion and the blood and all that things, it's not helpful. The baby will swallow it and eat it. It's a very good food for the baby. So do not take the stomach content, because when you take it, it's a risk for hypoglycemia. and you
I'm
stimulate.
sorry, can you repeat this one?
Never ever
The internet is very bad.
Intranasal or gastronasal or orogastric or nasogastric tube. No need. Just suction the mouth. Do not put the feeding tube inside. Nasogastric or orogastric. Never ever. You're harming the baby. Don't do that. There's two reasons why you harm the baby. You stimulate the vagus and you cause bradycardia in a tired baby. Second, the content is from the mom. It's blood and secretion, but it's all protein. So the baby will swallow it and suction it. Absorb it. You don't need to take it out. If it's harmful, the baby will vomit it. So do not allow anybody to suction. You're harming. The suction is only mouth and their nose. Bulb syringe or mechanical suction. Of course, you can use feeding tube to suction. You can use Yangi, whatever you have to suction, but only the mouth and the nose. So we warmed, we positioned, we clear the secretion. That's our steps, because the answer to our 3 questions is no, the baby has no problem. How we dry? We have a pre-warmed sheets or towels. We put it on the baby, dry the baby, and then when it's become wet, throw it. And so what we do usually, 2 people put the 3 sheets, dry the baby, and when become wet, one baby carry the baby, 2 hands, and then throw this one, put in bag, and keep drying. Very important to dry. So clear pre-warmed sheets, replace Wasit West, and I said 3. I was generous. Here it said 4. So we finish. If we go back, we finish the routine care. The difference, if the answer is no, we add stimulation. So the same step of routine care and initial step of an RB. Initial step, same, warm, position, clear, dry, but also we add stimulation. How we stimulate? Never vigorous, never ever, gentle. So what we do, rub the bag, tubercle bag, up and down, not from side to side, up and down. Never do from side to side. You will cause renal damage. Up and down. You slap the sole or you flick the sole. That's only the stimulation is allowed. Never carry the baby from the leg. Always support the head. Remember these, because all the resuscitation is about saving the brain, because all the other problem will recover. Any question? Any question? Am I slow or fast? Do you understand?
Yes, doctor.
Good. Do you guys like it or I'm boring?
It's good, it's good.
It's good.
Okay. Wrong stimulation. See this one. You guys see it? See this, carrying the baby from the leg. In Canadian law, this will suspend your license and they can take you to the court. And you might be jailed if you do that to the baby. Also, do not squeeze the chest. Do not stimulate from the front. Do not rub the chest. Do not rub the abdomen. Do not hit the back. Do not hit the back. Do not rub the abdomen. لا تفرك البطن. لا تفرك الصدر. Don't squeeze تعصر chest. Never carry from the leg. The stimulation that allowed, rubbing the bag up and down, flicking the sole, and slapping the sole. Slapping by finger, not by your hand, by finger. Because remember, the baby is weak. If the baby is not breathing to this stimulation, then he needs ventilation. Okay, so we're going back. Birth, question 3. Yes, routine care. No, initiate NRP. Routine care, same like NRP, the extra is stimulation. From here to here, 30 seconds. So we assessed, we did all these steps in 30 seconds, and then we assess again. What we assess again? We answer 2 questions after the initial step, which is 30 seconds. The second, remember, in NRP, the assessment, the questions always faces shape. Can be triangle, can be diamond, it can be whatever. So what is the baby apneic? And we will talk what is apnea. Is baby gasping? And we will also answer later on what is gasping. Is the heart rate below 100? Again, the answer is yes or no. So you don't need to say the heart rate is 99 or 60 or 70. You just say above 100, below 100. That's all what you need, because there is no time. So if the answer is no to these questions, he's not apneic, he's not gasping, and his heart rate above 100. That you ask another question. Is the breathing labored? Which means, is he has a breathing difficulty? Is there is accessory muscle use? Is he cyanosed? So answer either no or yes. If no, resuscitation terminated. Go to monitoring care. What is monitoring care? Same like routine care, but you add checking the vital signs. You need gas, you need blood gas, you need sugar, you might need to do sepsis workup and start antibiotic for infection. If baby is apneic or gasping or heart rate less than 100, you go to the second step of NRP. You provide positive pressure ventilation. You connect the baby to Massimo saturation monitor to check the saturation, and you connect the baby to cardiorespiratory monitor, ECG monitor. That's what's your step. You will talk about it. No, the answer is no, and baby is labored breathing or cyanosis. You position again, you clear your airway, but now you need oxygen. With the oxygen, you might need to give CPAP, which is continuous positive airway pressure. I don't need to speak about it, but if anybody interested, I can. I have videos on YouTube, you guys can check. So I'm going back. Assessment, decision, intervention, 30 seconds. What is the assessment? Second step, apnea, gasping, less than 100. Yes, provide PVV. Connect to the monitor and connect to ECG. No, ask another question. Difficulty in breathing, cyanosis, yes. Position, airway, give oxygen, consider CPAP. No, go to monitoring care. We said the assessment are two questions, apnea, gasping, or less than 100. What's apnea? It's cessation of breathing for 20 seconds. Or cessation of breathing for less than 20 seconds, but with heart rate less than 100 or blue color change. So that's apnea. What's gasping? It's occasional breath and is not enough to see air entry. And is not enough to give you oxygen to the body. So when you put the SAT is low. So gasping, apnea, heart rate below 100. How we check heart rate below 100? We check it over 6 seconds. And we check it by stethoscope, not by checking the umbilical cord, not by checking the pulse, not checking it by carotid. We check it by stethoscope. So you put a stethoscope in your ear and then you hold your finger like this. You don't talk. And then with the heart, you do like that. And somebody is counting. You count over 6 seconds. And why 6 seconds? Because you need to multiply it. So if it's 6, then it's 60. If it's 8, then 80. If it's 10, then it's 100. So again, not by feeling the umbilical cord, not by feeling the carotid, not by hand, not by seeing the pulsation. It's by stethoscope. How? To spend time, you don't count and then tell. No, you listen by your stethoscope and you hold your finger like that. And then you listen to the heart and you do like this. And people who's taking care of breathing and the other one who's taking of cardiovascular will count. And you only need less than 100, above 100. You don't need to count. What is cyanosis? Because we said labor breathing, cyanosis. Labor breathing means breathing difficulty. Cyanosis, discoloration of skin and sclera. Why? Because your carboxyhemoglobin is more than 5% of the total hemoglobin. It can be central, it can be peripheral. But we're talking, when we say cyanosis, we're talking about central cyanosis, the cyanosis that you see it on the lips. So of course, you are a very bad team. You're not doing a good job. If you see the cyanosis, you should see because, for example, if your hemoglobin is 15, to get cyanosis, you need 5 grams. So that's your hemoglobin is 10. Your hemoglobin is 15, let's say 20. Your hemoglobin is 20. So you need 5 grams to see the cyanosis. So that's 5 out of 20, 25. And that means your saturation going to 75 because you're losing 1/4 until you get cyanosis. So if you're connecting your sat monitor, you will see the saturation going below 90. You have to take action. You don't leave the baby to go down to 75 to make action because cyanosis is too late sign. Because remember, cyanosis, when you're losing 5 grams of your hemoglobin, instead of being oxyhemoglobin, it starts to be carboxyhemoglobin. And 5 grams out of 20 is 25. So 75 is oxygenated, 25 is not oxygenated. So if you put SAT monitor, the SAT monitor will discover the oxygenated. That means your SAT saying it's 75 until cyanosis appear. So you don't need to reach to that point. You have to pick up the baby prior that. So we said apnea, gasping, cyanosis. Labor breathing is breathing difficulty. Use of accessory muscle. So remember, when we answer the questions, apnea, gasping less than 100, and the baby has a labor breathing or cyanosis, we said give oxygen. Deposition, we cleared the airway, now we need to give oxygen. How we give oxygen? We can use simple mask. What simple mask means? Simple mask means that you don't have flow controller at the entry of the mouth of the mask. You have 2 openings and they are open. So that mask is a rebreathing mask. Now, I don't want to go to details of what is the meaning of simple mask, but you can supply the oxygen with simple mask. Or you can give by nasal cannula. Or you can use flow inflation bag. Flow inflation is the bag used by anesthesia.
ما الفرق قبل اشوفك لا هاي لا هاي
Or you can use your hand as a cup. And whenever you give oxygen to your baby, you don't use the flow. You have to use air oxygen blender. What is that? It's an oxygen source, an air source, and the blender, the mixer, put them together and going to the baby. The air source will give you the flow, and the oxygen source will give you the oxygen. So don't depend on the flow like an adult to give oxygen. So if you don't have a blender, then you have a problem in your hospital. Nasal cannula, it's like mishnata. have two nasal prongs, and you insert it to the nerves, and there you can see these two, you can replace it, and it's connected to the air oxygen blender. Flow inflation bag, you can give oxygen with it, composed of the bag, the valve, the gauge, the valve, the gauge, the oxygen source, and the mouth part. You can use cup. The styrofoam, you can use it and puncture it from here, put the oxygen source and use it. You can use colored one for either if you're dealing with, of course, for children, they may cry. So you can use cup with cartoon characters on it, so they make it more familiar. You can use directly the tube to provide oxygen. And remember, you should have this. If you don't see this, then you have a problem. Oxygen source, air source. How I know? Always oxygen source, the tube is white. Always the air source, the tube is black. The suction tube is yellow. So you see two tubes, two entrance, one oxygen, one. Here you control the flow of the air, and here you control the gauge for oxygen percentage. Remember, we breathe room air, but you can give up to 100%. That does not mean that the baby receiving 100, because you are mixing oxygen with air. So if you give 100 and flow, let's say, of 10, we don't reach to 10 in newborn babies, of course. Let's say 4, so the baby might get in 65. So it's very important to use air oxygen blender. Otherwise, you're ending, if you don't use a blender, you end up using CPAP-like, but it's unmeasured. So always remember that there should be air oxygen blender. Or we can give CPAP. Instead of only oxygen, we can give CPAP. And this is one example of CPAP machine. It's give oxygen and pressure. And pressure, I'm gonna ask everybody, what is pressure? How we generate pressure? I'm gonna unmute all, I need answers. How we generate pressure? Anybody know? Anybody?
No, actually, I don't know.
How you generate pressure?
بابا ليش حبيبي ليش؟
How we generate pressure? Anybody? Anybody know? Anybody know? Okay. So imagine yourself. Because it's noise.
Chest movement, chest massage.
Sorry, again, what's the answer?
Chest massage.
What is chest massage?
Chest massage.
How you generate
Cardiac
pressure?
massage.
No, how you generate pressure in the room, in the outside? How we get pressure? The question, how we get pressure? Anybody want to answer, he can unmute himself or herself and answer. To generate pressure, there's two ways. Imagine yourself at the highway and holding a paper, and then a truck pass by. A truck, the paper will be sucked with the truck because there is negative pressure created. This is called Venturi phenomena. That's one way of generating pressure. The second way is the flow against a sealed place. So if you have a room and it's sealed and then you put flow in it, you get pressure. So what is CPAP? Is a flow against valve. You get pressure. And then you give to the baby a pressure to supplement to splint the upper airway and inflate the chest. With the pressure, you can give oxygen. The difference between nasal flow without blender and CPAP, they are the same, but CPAP is measured. You can see the number. So I don't want to go to details of that, but you can give only oxygen, but you can give CPAP. So remember, we gave oxygen, we gave CPAP because of cyanosis or labor. How we give PPV? positive pressure ventilation. It can be by flow inflation bag. It can be by self-inflation bag. It can be by T-piece or neopath. We'll talk about it. How many times I give to the baby when I do positive pressure? 40 to 60 events. And this is only for newborn, not for adult or pediatric. What is that? You squeeze the bag for 40 to 60 times per minute. Use flow inflation bag or self-inflation bag or T-piece. What's flow inflation? It's a bag connected to gauge and pop-up valve, safety valve. So if you give more pressure, it helps you to release it. Face mask and tube connection to the flow. Here, there is a valve. Sometimes there is a valve that you can close it and open it. And sometimes people like to close it by their hand. When they are skilled, they like to close it by hand. So you hold it from here and then start squeeze. And the pressure goes to the baby and you're giving oxygen at the same time. So this, to work, you need flow. It cannot work without flow. That's why called flow inflation. So without connecting to flow source, you cannot. And again, when you use it for a baby, it should be connected to oxygen air blender. So it's called flow inflation or anesthesia because the anesthetist always connected it to their breathing circuit so they can give some PPV when they are ventilating, called anesthesia bag. Okay? Or you can use self-inflation bag. And it's again composed of the self-inflation bag, the pressure relief valve, the pop-up valve, the mask. The mask contains of mask cushion so you don't damage the baby, injure the baby. And this, the mask inflation, sometimes this cushion inflated by air. So you put syringe and inflate it. You have a reservoir because when you squeeze, the air goes out. The reservoir can be closed, can be open. And then you have oxygen source. Here, you don't need a blender. You just need source because the flow generated by self, not like flow inflation valve. You don't need flow to work. With or without oxygen, it works because when you squeeze, it de-squeeze itself after you relieve your hand. So you can use flow inflation bag, you can use self-inflation bag, you can use something called T-piece. The T-piece or neopath, it's the same way. The difference, it's dangerous, of course, I don't recommend anybody using it, but the machine determines how much you squeeze and how much you relieve. And when you put your index finger in here, it gives PPV. When you relieve it, it releases. So it's help for long-term ventilation. I do not recommend it. So the second step of NRB, give PPV, and then check the saturation. Again, we said when you give the PPV, whether by flow inflation or self-inflation or T-piece, it's 40 to 60. How you do it? You say breathe, 2, 3, breathe, and 2 and 3, and breathe. Breathe, and 2 and 3, and breathe. And 2 and 3, and breathe. Breathe, 2 and 3, and breathe. And 2 and 3, and breathe. And 2 and 3, and breathe. And 2 and 3, and breathe. If you do that, then you're giving about 40 to 60 breaths per minute. Remember, when you squeeze, don't squeeze hard. If you don't know, then open your safety. Because when you give more, you can go to pneumothorax. So you can open this, or people say, if you squeeze by two finger, thumb and index, you're giving 10. If you use 2, you are giving 20. If you use 3 and thumb, you are giving 30. So if you need, that's a eyeballing, I would say, judgment call squeezing. But it's best way to squeeze whole, but open the safety valve, because when you go more than 30, it will release. And after you gave PPV, now you check your saturation. How you check it? You use the Massimo, composed of probe and connected to the machine that give you the reading. You always use right hand because it's preductal. The postductal will be less because of mixing of deoxygenated with oxygenated. If you have a premature baby, you are targeting a reading of more than 88 but less than 91. Why less than 91? Because if you don't target that, you will give more oxygen. And if you give more oxygen, it's not good. In term baby, you target more than 94. How you do ECG? You put 3 chest lead, ready-made. Always make it like a triangle. So that's the first step. And the second step of our algorithm of resuscitation. Now we said we will check resuscitation, and we'll check the oxygen. But the oxygen will never, because remember when a baby inside, his or her oxygen was very low. So it needs time to build. So when you connect your SAT monitor, you target these. So you don't give excessive pressure, excessive PPV, excessive oxygen for no reason. And then look at this reading. So it's in front of you, it should be in front of you, and you target it. And remember, this is a preductal. If it's postductal, it's by 10% less. So we gave PPV, we've connected the SAT monitor, and we connected the chest monitor. So we did our assessment, we did our action, another assessment. Now only one question. Breathing is not a concern anymore. Is the heart rate less than 100 or above 100? If the heart rate after the PPV of 30 seconds is more than 100, then check chest movement. No. Sorry about that. I'm just pausing because I thought I did mistake. If the heart rate is more than 100, mean it's not less than 100, then you go in this way. So what is extra here? You do debriefing with your team. But remember, when we go back, we have 2 ways to reach this. We have either apnea, gasping, or heart rate less than 100, and we did PPV, or no, we don't have these, but we have cyanosis or labored breathing, and we gave CPAP. So we had 2 pathways to reach this, either this pathway or this pathway. So if the baby responded to second step of an RB, then we do what we call it post-resuscitation team debriefing. How we did, what was wrong, what went well, how we can improve next time. They call it post-resuscitation team briefing. Who was assigned to what? Was the tone appropriate? Anybody is not happy? Anybody felt insulted? Anybody to know anything? So you do debriefing. By this, you keep your team integrity very well. You did PPV, you check your oxygen, and you have your EEG, but your heart rate less than 100, continue. So if your heart rate after the second step less than 100, check chest movement. When you do PPV, do you see chest rise? Auscultate. Do you see good air entry, bilateral, symmetrical? You might need to check for pneumothorax. You might need to consider intubation. Or you might need to consider laryngeal mask airway. We'll talk about it. Again, check chest movement, auscultate, you might need to intubate. You might need to use laryngeal mask. What is laryngeal mask airway? It's like a mask on the nose, but instead of the nose, it's mask the larynx. It's of different sizes, and there is special technique to insert it. So instead of simple mask on the nose, it becomes a mask on the larynx, laryngeal mask airway. If you don't have ETT, or you don't have people skilled to intubate, then you can use laryngeal mask airway. Almost always you can save the baby with laryngeal mask airway. There is a person, 07822689063. I cannot allow people with nickname to go in. I need the real name. I allowed him or her to be in, but next time I won't allow it. I need the real name. So, what we do with post-resuscitation team debriefing to a baby responded to second step of resuscitation. As I said, what went well, how we can improve, how the staff feeling. Did anybody spoke in a high tone? Did anybody insult anything in the body, any belief, anything? How we can improve? Gender insult, seniority insult, religious insult. Anybody has any problem? Anybody felt that something need to be improved? Anybody who has no good skill that you need to improve in that or this area? Team debriefing is good for that. So we've reached to here. Either improved and the heart rate is above 100, then or here, and we've talked about our target. So the heart rate is less than 100. We've checked. Chest movement is good. Good air entry, no pneumothorax. We thought that we don't need ETT or laryngeal max airway. After 30 seconds, we check the heart rate again. No, the heart rate is above. We go to post-resuscitation team debriefing, the third step, debriefing. Yes, at this point, we need chest compression. So we need PPV coordinated with chest compression. If you are giving oxygen less than 100, you make it 100. You need cardiorespiratory monitor, and you might need emergency UVC. How we do chest compression? Two ways. Two-finger technique, or two-hand technique, or thumb technique, and two-finger technique, or one-hand technique. So, in one-hand technique, you'll have one more hand free, but in two-hand technique, you need one. You might need to change your position from where you are ventilating when you do the chest compression. So you draw line between two nipples, and then you put your two finger over the sternum, and then you start to push in. The push should be hard, and it should be 1/3 of anteroposterior diameter of the chest. Same in here. You grab the chest by both hands, you put your thumb over the sternum, at the line, below the line between two nipples, and then you squeeze. It should be 1/3 of the anteroposterior diameter of the chest. So you, instead of 2-3, it will be 2-3 compression, breathe. 2-3 compression, breathe. 2-3 compression, breathe. 2-3 compression and breathe. By this way, you're giving about 40 to 60 breath per minute, and you're giving 100 chest compression by minute. Every 2 minutes, you need to switch, whoever doing the chest compression. This is the way how we do it. Flow inflation bag, chest compression, thumb technique. Positioning, see the positioning, the shoulder roll. So squeeze, 3, 2, breathe. 3, 2, breathe. 3, 2, breathe. 3, 2, breathe. And then you continue and switch after 2 minutes. So here you reach. You gave all of that. You check the heart rate. Now you check your heart rate, and here we are. Is less than 100? This is wrong. Sorry, this is wrong. Here you have to answer 2 questions. Is it more than 100 or less than 60? So if it's more than 100, you go to debriefing. If it's between 100 and 60, you do chest compression. If it's less than 60, you need epinephrine. The epinephrine can be given IV, can be given through the tube, tracheal tube, if the baby is intubated. You might need to consider volume bolus. You might consider pneumothorax. How we administer epinephrine? It's 0.01 to 0.03 milligram per kg, which means 0.1 to 0.3 mil per kg of 1 in 10,000 concentration. And only indicated not less than 100, that is mistake, when you're doing PPV and chest compression for 30 seconds and the heart rate less than 60. You can give it in the ETT, you can give it IV, maximum is 3 times. So how we do? We do chest compression, PPV, 30 seconds, we give epinephrine. We do chest compression, PPV, 30 seconds, and we give epinephrine. We do chest compression, PPV, and epinephrine, and then we give epinephrine. 3 times, each time should be 3 seconds. Remember, 3 seconds is holy secret. Again, if you remember this from the beginning, so we have 3 types of care: well baby care, monitoring care, intensive care. Well baby care, no, answer to the 3 questions is okay. Monitoring care responds to the initial step of resuscitation. Intensive care is no response to initial step of resuscitation. What we do in intensive care? We do post-resuscitation care. We transfer the patient to the NICU. We need respiratory help. We need cardiac help. And we start our initial course in the NICU. Who need the initial post-resuscitation care? Any baby who gets apnea, gasping, or heart rate less than 100. That's to the NICU. Labored breathing and the heart rate is more than 100. This is an ICU. If the heart rate less than 60, what we do, we start sugar. In my unit, the target is the sugar start within 20 minutes. We might give CPAP. The sugar starts within 10 minutes. So caffeine also we give. When we give caffeine, our target is within 30 minutes. We might need to give lines, peripheral IV, umbilical venous catheter, and you might need arterial catheter. You might need to give surfactant, you might need to intubate and connect the baby to breathing machine. Why you fail resuscitation? Joseph Zakor, angiotube role in decreasing intra-abdominal pressure in case of that. Wow, that's a very specific question, Joseph. That is not for medical students, these questions. And diaphragmatic hernia has a special way of management. Not only the feeding tube, everything is different. Diaphragmatic hernia should be cared by tertiary center. So I'm not going to discuss it now because we have a medical student. So why we fail? a response to positive pressure ventilation, you have a block by different reasons. Or your function is not working, or your lung is not working because of pneumothorax, fusion, dramatic hernia, as Joseph was asking, hypoplasia, pneumonia, RDS. So that's one of the reasons why you fail. If you give oxygen and there is no response, no labored breathing, then think of congenital heart disease. If there is persistent brady and you're giving epinephrine and you're ventilating very well, then think of heart block. If you have apnea, then think of hypoxic ischemic encephalopathy or neuromuscular disease, or mom taking some medication like diazepam. When to discontinue resuscitation? After 10 minutes of effective resuscitation. What is effective resuscitation? PVV with chest moving, good chest compression, and 3 doses of epinephrine. And if all that, after 10 minutes, you don't have heart rate, no respiratory effort, then you have to stop resuscitation and declare the patient or the baby died. When you do not resuscitate, always the decision should be by parent. You cannot not resuscitate a baby and the parents say resuscitate. Whatever the reason, whatever the cause, even if the resuscitation is futile, if the parents say resuscitation, morally and legally, you have to resuscitate. So you cannot stop resuscitation without the permission of the parent. When you want to withhold resuscitation, always resuscitate, transfer the patient to an ICU, let the parent absorb the shock, and then make the decision. Follow your facility policy. We do not resuscitate babies less than 22 weeks. Or if you have a diagnosed fatal multiple malformation. When you do not resuscitate, you go for comfort care. What is comfort care? You provide oxygen, you prevent pain, and you provide food. That's comfort care. So you keep the baby with these 3 conditions. You warm the baby, you give oxygen, you give food, and you prevent pain. When you do comfort care, you can give whatever, even narcotics, stop pain from the baby. And remember, baby feel acute pain and chronic pain. Remember, you cannot do anything with baby. Don't say the baby is not feeling pain. Actually, I do research on that, and the baby feel pain more than adult. I don't know if I have time to give you some videos, but I'm happy to take questions.